Hello, my name is Gerald Gant, and I'll be discussing Clostridium difficile colitis when it's bad, when to operate, what operation, and special situations. I have no disclosures. Clostridium difficile infection, or CDI, is the most common cause of nosocomial diarrhea and accounts for 20% of antibiotic-associated diarrhea. During the beginning of the millennium, there was a 47% increase in incidence from 2006 to 2010 compared to 2001 to 2005. However, in more recent years, the cases of C. diff infection have plateaued with roughly 460 to 470,000 from 2011 through 2017. Of these patients, approximately 3 to 8% will develop fulminant colitis. It's important when we talk about C. diff infection that we use common nomenclature. Patients with severe complicated or fulminant disease or toxic colitis are those who are usually considered for surgical intervention. Severe complicated or fulminant disease is defined as CDI with associated hypotension, shock, sepsis, ileus, megacolon, or requiring ICU care. Toxic colitis was referred to as patients who have the same symptoms as well as signs and symptoms of peritonitis. Of all patients with CDI, surgical intervention is needed in approximately 0.17 and 3.5% of patients. Of patients with severe complicated or fulminant CDI, about a third will require surgery. However, it's difficult to predict which patients will have resolution of symptoms with medical therapy alone. We do know that there's improved survival with subtotal colectomy or total abdominal colectomy compared with medical therapy. This is evidenced by a meta-analysis, which included 510 patients. Here you can see that there's an association with improved survival for patients who were managed with subtotal colectomy compared to medication alone. So when do we operate? Colectomy performed after initiation of vasopressors or end organ dysfunction is associated with increased mortality rates. We know that there are a number of predictors of mortality that have been discovered through various retrospective analyses. Some of the ones that occur frequently are elevated lactate, severely elevated leukocytosis, or an hypoalbuminemia. Decreased albumin can be associated with mortality because we know that albumin binds to the C. diff toxin. Other predictors of mortality include electrolyte derangements and elderly patients. We also know that decreased time from presentation to surgery is associated with decreased mortality. In one such meta-analysis of patients with C. diff infection, those who were taken to the OR more than 3 days after admission had increased mortality rates with an odds ratio of 1.09. So the key is the early identification of failure of medical management or deteriorating clinical status. This requires early surgical consultation and evaluation of patients with severe, complicated, or fulminant CDI. When the decision is made to perform an operation, which operation is ideal? Has been recommended over the years, a total or subtotal abdominal colectomy with endoleostomy is the gold standard. This requires removal of the abdominal colon at least to the rectal sigmoid junction. This allows for a source control without pelvic dissection. The residual rectal stump can be managed with or without transrectal drainage or mucus fistula. We know that this is a very morbid operation with mortality rates ranging from 40 to 60%. In one meta-analysis, one series of about 50 patients, the mean survival was 18.1 months and the median survival was 3.2 months. And with long-term follow-up, only 1 out of 5 patients had their ileostomies reversed. Although total abdominal colectomy has been recommended by a number of societies, there are a fair amount of segmental colectomy still being performed for CDI. This is less than ideal because we know that CDI is a luminal disease and cannot be properly assessed through examination of the serosal surface of the bowel. We also know that about 16% of patients who undergo a segmental resection will need additional resection during the same hospitalization. And then this group analysis from data from 2007 and 2015, looking at 733 colectomies for C. diff infection, about 1 out of 5 were partial colectomies, despite the association's guidelines. Interestingly, there were no differences in length of stay, 30-day mortality, or complication rate. Due to the associated mortality and morbidity with colon resection, another operation has been proposed over the past decade, which involves diverting loop ileostomy and colonic lavage. The idea behind this is that this may be more palatable to patients earlier during their hospitalization and can potentially result in earlier in operation. Could also result in obviously colonic preservation and decreased morbidity of a potentially permanent ileostomy. The indications for ileostomy colonic lavage, as originally described in 2010, are essentially the same as for patients requiring colectomy. The initial series, published in 2011, analyzed 42 patients who underwent ileostomy with lavage with worn polyethylene glycol and vancomycin. This group of patients was compared with a retrospective cohort. The initial findings were encouraging, as there was a decrease in mortality from 50% in the retrospective cohort to 19%. Of those patients who underwent ileostomy with lavage, 2 patients required reoperation, 1 for abdominal compartment syndrome and 1 for resumption of vasopressors. Subsequent studies comparing total abdominal colectomy, ileostomy, and lavage include a multi-center retrospective study, which included 10 medical centers from 2010 to 2014. A total of 98 patients were involved. 77 patients underwent total abdominal colectomies and 21 underwent ileostomies. There was no difference in overall mortality. However, the adjusted overall mortality was 17.2% in the ileostomy group compared to 39.7% in the total abdominal colectomy group. There were no difference in complications. Obviously, all of these retrospective series are limited by selection bias. Another review of the national inpatient sample looked at trends of total abdominal colectomy versus loop ileostomy performed for C. diff infection. And here you can see that from the first quarter of 2011 through the third quarter of 2015, the proportion of surgeries performed for C. diff infection that were loop ileostomies increased from 10% to 36.8%. So there was some adoption of this technique. The study found that the patients undergoing loop ileostomy were younger, the average age of 60 compared to 68, and were more likely to have private insurance. Interestingly, there was no difference in mortality between the 2 groups. A more recent meta-analysis, which included 5 studies and over 3,500 patients, found that, again, there was no difference in mortality between the total abdominal colectomy compared to the diverting loop ileostomy groups. However, the major difference was in the rates of ileostomy reversal, with 80% of patients who underwent a diverting loop ileostomy having the ileostomy reverse, compared to only 25% of those who underwent a total abdominal colectomy. There are some other considerations for patients undergoing surgery for C. diff infection, namely the management of an IBD patient with acute C. diff infection. We know that IBD is a risk factor for developing CDI and for requiring surgery. This is further complicated by overlapping clinical presentation, which can delay diagnosis of CDI. PCR testing for CDI is recommended for IBD patients presenting with unformed stools. We also know that steroid use is an independent risk factor for worse outcomes and is predictive of surgery within 1 year following C. diff infection if the dose is escalated during the acute episode. Ulcerative colitis is associated with an increased risk of undergoing colectomy with an odds ratio of 1.9. The overall indications for surgery remain the same as patient population, so the acute management should not change. In a meta-analysis of over 40,000 IBD patients with CDI compared with 1.3 million IBD patients without CDI, it was noted that there was increased mortality associated with IBD overall and ulcerative colitis in particular, but not Crohn's disease. This may be due to the pathology of Crohn's disease and that many of these patients may not have had chronic disease. One limitation to all of this data is that a large number of it is meta-analyses, and there's very little randomized trials for patients with an acute significant C. diff infection. For patients with IBD, current AGA guidelines recommend postponing escalation of steroid therapy in the setting of acute CDI for 72 to 96 hours after initiation of antibiotic therapy. In conclusion, delayed operative intervention increases mortality in fulminant C. diff colitis. Early surgical consultation and intervention based on laboratory values and clinical evaluation may result in decreased mortality rates. Diverting ileostomy with lavage may obviate the need for colectomy and improve colon preservation and stoma reversal rates. Thank you.